Hello, everyone, and welcome to the Agency for Healthcare Research and Quality's webinar on transforming guidelines into action, clinical decision support at the point of care. Although a few people are still logging in, we are going to get started on time. My name is Mario Teran, and I will be today's moderator on this webinar. I currently serve as a physician informaticist for AHRQ's Digital Healthcare Research, or DHR program, which is part of the Center for Evidence and Practice Improvement. Our mission at DHR is to produce and disseminate evidence about how the evolving digital healthcare ecosystem can best advance the quality, safety, and effectiveness of healthcare. To fulfill this mission, the program funds research that yields actionable findings around which digital healthcare technologies can improve care for our key stakeholders of patients, their caregivers, clinicians, and health systems. We will discuss 3 of these exciting research projects during today's webinar. The agenda for today's webinar is now displayed. Please note, we are recording this webinar and the recording and slides will be available on AHRQ Digital Healthcare Research website in a few weeks. You'll be notified by email once they are available. We are extremely pleased and honored to have with us today an esteemed group of presenters. They include Dr. Patricia Dykes, Dr. Alex Baropoulos, Dr. Kensaku Kawamoto. This webinar is accredited by Affinity CE. If you are interested in receiving continuing education credit for participating in this activity, information on how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. For purposes of accreditation, let me note that AHRQ, SD Solutions, and Affinity CE have no financial interest to disclose. Dr. Dykes also has no relevant financial interest to disclose. Dr. Sparopoulos has received research support from Boehringer Ingelheim and Janssen. He is also consultant for Janssen, Bristol Myers Squibb, AstraZeneca, and Sanofi. Dr. Kawamoto has received a book chapter honorarium from Elsevier and sponsored research by Hitachi. He is the co-developer of MD Aware and consultant for Pfizer, RTI International, Security Risk Solutions, and Regent Street Foundation. Also, please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the question and answer panel located to the right of the PowerPoint slides. Please include the presenter's name on their presentation order number, such as first, second, or third, with your question. As a reminder, participants are in a listen-only mode, so to ask questions, you will need to use the Q&A panel. This slide shows the learning objectives for today's webinar. By the end of this presentation, we all should be able to discuss the historical path for developing CDS tools and the data-related issues that limit sharing CDS across organizational boundaries. Identify new modalities for CDS development and implementation that offer true vendor-agnostic capabilities, such as service-oriented architectures, or SOAs, that are capable of fast healthcare interoperability resources standards, known as FHIR. Demonstrate an understanding of how shareable tools can be adapted for integration into an electronic health record system, or EHR. And now it is my pleasure to introduce our first presenter, Dr. Patricia Dykes. Dr. Dykes is an associate professor of medicine at the Harvard Medical School and the research program director for the Center for Patient Safety, Research, and Practice at Brigham and Women's Hospital in Boston. Her research aims to improve quality and safety through patient engagement and CDS. Dr. Dykes is currently leading patient safety informatics clinical trials to improve fault prevention and care transition in primary care for patients with multiple chronic illnesses. She is also leading the development of CDS and an electronic clinical quality measure to prevent and quantify delayed diagnosis of venous thromboembolism. In addition, Dr. Dykes is the site PI for the CONCERN study, which uses data science and machine learning approaches to identify hospitalized patients at risk for deterioration. And now I would like to turn control over to Dr. Dykes.
Thank you, Mario, and hello, everyone. I am really pleased to have the opportunity to share the work that our team has done for use in for developing Aspire, which is patient-centered fall prevention, clinical decision support for use in primary care with community dwelling older adults. So I have two objectives today. The first is to discuss the historical path for developing clinical decision support tools and their limitations for data sharing across organizational boundaries. And second, to describe the Aspire project and how it aims to overcome traditional fall prevention limit and CDS limitations. So first, the Aspire project filled an existing gap in primary care fall prevention by providing CDS that guides primary care providers and patients to make the most effective individualized fall prevention strategy and to ensure that patients can actively participate in minimizing the risk of having a fall and suffering its devastating consequences. So I want to start by acknowledging that the development of CDS tools has really followed a historical path, evolving along advancements in healthcare technology. So I completed my PhD in informatics in 2004. I couldn't wait to come up here to Partners, as it was known then, because it was one of only a few informatics centers in the US. However, even here, we did have a fully functional outpatient electronic health record, but there was very limited data from inpatient encounters, and there was very little nursing data. But this wasn't unusual because before the HITECH Act, the adoption of EHRs for office-based physicians was less than 50%. In the United States, there was limited data and data exchange. There was uneven adoption of standards. Therefore, many CDS systems were standalone and they were poorly integrated into practice. Now, over the past, decade and more, with the passage of the HITECH Act, the Meaningful Use Program, we have seen incrementally better adoption of EHRs. We have better data capture and gradually better integration, more uptake of standards. We'll hear a lot about use of standards today. There's more recognition of the importance of patient-family engagement and use of health IT. Today, we have almost universal adoption of electronic health records, and we have improved access to data. We have improved interoperability, and now we have decision support that can access data from multiple systems to provide CDS related to individual patients, as well as for use with population health management. But despite the progress that we've made in this near ubiquitous access to data, unfortunately, there's still limited examples of decision support that uses EHR data to make tailored recommendations at the point of care. And so today I'm going to talk about the Aspire project, where our team developed CDS that uses EHR data to make tailored fall prevention recommendations in the context of a primary care visit based on patient-specific determinants of risk. So the goal of the Aspire project was to develop CDS that uses widely available EHR data to improve fall prevention management in primary care settings. The backdrop is that community-based falls are a leading cause of death and disability in older Americans. Decades of research exists to support the use of interventions that are tailored to patient-specific risk factors. And there are resources that exist, but they're just not integrated into clinical practice. So I was the partner's PI for the NIA and PCORI-funded STRIDE study. It was a very large fall prevention study that aimed to integrate fall prevention evidence into practice. As part of that study, we developed a set of algorithms linking all the major fall risk factors for community dwelling older adults to evidence-based fall prevention care plans. However, we found that not all the fall risk factors can be easily addressed in primary care, and that unless these algorithms were integrated into the EHR as decision support, they couldn't be easily adopted. And so the reality is that today, fall risk screening is routinely done. It's required by the Joint Commission. It's done for every visit, but there's often no decision support to address fall risk when it's present. So our goal with Aspire was to develop fall prevention CDS that can be integrated into primary care practice to guide providers to the most effective fall prevention strategies for the individual patient and to engage patients and family in fall prevention decision making. And we had two specific aims. The first was to prioritize the use of the STRIDE evidence-based fall prevention guidelines to be translated and disseminated via the Aspire CDS. And as a sub-aim to author and test the Aspire CDS computable fall prevention guideline algorithms so that we could generate actionable, implementable, patient-centered CDS using the CDS Connect resources. And then our second aim was to conduct formative and summative evaluations of the Aspire CDS and the care plan collaboration tool in rural and urban primary care settings. So our first step for AIM 1 was to prioritize the STRIDE algorithms for CQL translation. And the STRIDE algorithms address the most common reasons community dwelling older adults fall and sustain injuries. So we first re-examined the literature to see if there was any new evidence that needed to be included for each risk factor. We also performed a gap analysis of the EHR data needed for the algorithm versus what was available routinely in the electronic health record. And then we presented and discussed the strength of the evidence, the data availability with our research team and also with our multidisciplinary advisory board, and then selected the priority risk factors that we would include in Aspire. And so we included in the CDS the activity and exercise, fall risk increasing drugs or FRIDS, and osteoporosis. So next we use the CDS Connect resources to translate our paper-based algorithms into computable fall prevention guideline algorithms that could be used to generate actionable and implementable patient-centered CDS here at Mass General Brigham, but it also allows us, using these tools to share the CDS more broadly. So the product of AIM 1 was three CDS artifacts. We have exercise guidance for primary care fall prevention, primary care management guidance for fall risk increasing drugs, and osteoporosis management guidance for primary care fall prevention. And these artifacts are available today on the AHRQ CDS Connect site for dissemination. They can be implemented as decision support by healthcare organizations that would like to integrate evidence-based CDS into primary care workflows. So after developing the computable guidelines, we started on AIM 2. We developed the Aspire middleware that enables primary care providers with different EHR vendor systems to launch the tool from within the EHR and develop actionable fall prevention plans with the older adults who screen positive for fall risk. So we developed the Aspire middleware using a participatory design approach, both in the urban and the rural healthcare systems that had two different electronic health records. So first, we conducted stakeholder interviews with providers and patients to help us understand the current fall risk management practices. Then we did contextual inquiries to provide additional insight into staff thought processes as they engaged in fall prevention using their current electronic health record system. And then we conducted workflow observations to try to validate, provider reported workflows and insights that we had heard about in the other two methods that we used. And then we synthesized the data from the three sources into a journey map that visually depicts the fall risk management process in urban and rural primary care. Our goal being to not focus on what's unique to urban settings or rural settings, but what's common across those settings and what could we potentially leverage that would work in both settings. And then we use the findings from these activities to develop the initial wireframes and to get feedback from our stakeholders. And then we conducted formative testing where we secured iterative design feedback using a think aloud approach. Initially, we used a static prototype, just wireframes, for the first few sessions, and then we developed a clickable prototype in Figma, which is an interface design and testing program. And then following completion of the formative testing, the prototype was revised based on feedback, and it was integrated into the electronic health record system at the urban and in the urban setting, which was Epic, and the rural setting, which was using Athena Practice. And so there were several, several themes that emerged that informed our software design. And so before I show you the software, I thought I'd talk about some of those themes. One was workflow burden. So we did this project in the middle of the pandemic. Primary care practices were in a crisis with staffing. We heard that the software really needed to be completely integrated into the clinical and the EHR workflows. There was some skepticism about, whether it was actually feasible to use the software in the context of a primary care visit due to the time constraints. Many of the providers felt that, it was perhaps the Medicare wellness visit would be the most feasible type. We also heard about the importance of systematic communication between team members, but also with the patient and family, because fall prevention planning often involves behavioral or environmental changes. So having family member support can often improve or make the difference between adherence or non-adherence to prevention plans. We also heard about in-person assessment of patient condition, that this was, really important for providers to really understand patients' fall risk. So for example, providers told us that they often watch patients walk across the room and they assess their gait and balance during the visit. And then if it's abnormal, then they would include fall prevention, education, and engagement during the visit. During COVID-19 pandemic, the in-person visits became less common, making observation much more difficult. We also heard about the importance of personal support networks, that patients need a support network to successfully adhere to fall prevention strategies. Patient participants agreed that they could more easily maintain behavior changes, such as regular exercise or taking certain medications, when others were there to encourage them and also to hold them accountable. We heard about the importance of access to motivational tools. So providers told us they often look for ways to motivate patients to adhere to behavior changes, and most identified independence both as an extrinsic and intrinsic motivator. So patients acknowledged that external motivators such as exercise prescriptions that are quick and easy to complete were necessary to get them to start engaging in fall prevention practices. Some noted that knowing that an exercise would be quick and less than 15 minutes, for example, would be enough to get them to start to integrate it into their routines. We heard about the importance of patient understanding and acceptance of fall risk. So many patients reported that the fear that admitting that they're a fall risk could threaten their independence, that they would be labeled. Others noted that because they feel healthy and strong for their age, they didn't believe that they're at risk. And so it's important to create a tool that allows the provider to help the patient to understand their personal risk factors as the provider's learning them. And then individualized resources. So prevention discussions and plans need to be based on patient-specific risk factors and barriers. So a major barrier is that current electronic health records don't provide individualized fall prevention plans or resources. And then finally, exercise, which is quite effective fall prevention intervention, is often not recommended by providers. And they told us that this is because for people who are frail or unsteady, they're worried if they recommend exercise that the patient's going to fall. And so they really wanted to know, what exercises are safe to give patients. And, they wanted more expert guidance around that. So this is a picture of, I talked about the fall prevention journey map that we developed. So this work was led by our postdoc, Kristen Shear from University of Florida. As I mentioned, journey maps are used to better understand care processes, plus the motivations and the thoughts of those that are engaged in that process. In our project, we use journey maps to holistically understand the fall prevention management process across the urban and the rural settings, and then also to inform the training prior to go live. This is a screenshot of the Aspire Fall Prevention Care Plan Collaboration Tool. as it looks when it's opened up in the electronic health record. It's designed to assist the primary care providers in the three-step fall prevention care planning process in the context of that primary care visit. And so the first step is confirming the details of the patient's risk factors. And so these are presented to the provider based on the data that's in the electronic health record. In step 2, Aspire generates recommendations based on the selections that are selected or confirmed in step 1. And then step 3 allows them to review and to implement recommendations. So in step 1, the provider confirms the patient's risk factors. So again, we targeted mobility, FRIDS, and osteoporosis. And the risk factors are they're pre-selected based on the patient's electronic health record data. The provider can validate the risk factors with the patient. So the idea is they would share the screen with the patient and review the risk factors and edit as needed. In this example, Aspire pre-selected mobility and the bone health risk factors based on the electronic health record data, and it pulled any actively prescribed FRIDS. Providers asked us not to pre-select those because they often wouldn't address more than one FRID in a given visit. So they wanted to just see which the patients were on and then think about which they wanted to address. In step 2, the provider and patient can view the evidence-based recommendations, the talking points, and the patient education materials and make any changes based on that conversation. And so in Aspire, the recommendations are grouped by the risk factor. And here I'm showing you for the exercise, this patient has some, they must have some type of gait disturbance where exercise would be helpful, but they're safe to stand. So the recommendation is level 1 standing exercises. In step 3, the provider reviews the final recommendations. They edit and save the fall prevention plan, and then it's saved in their note as a progress note, and then it's also sent to the patient's after visit summary along with the educational resources. So, so that was the Aspire intervention. We did a summative evaluation. First, summative usability testing we conducted via secure video conferencing with audio and video recording. So at the beginning of the session, the facilitator provided a brief introduction of Aspire. They gave the participant remote control of the screen. Each session included 2 scenarios, and participants were randomized to determine which they would receive first. And each scenario included information about age, our standardized patients' age, gender, chronic diseases, general activity levels, assistive devices, medications, and then whether or not they had a history of osteoporosis or osteopenia. And then each participant used Aspire to complete 4 tasks. So the first was to be able to launch the tool from their EHR, the screens that they typically use in the context of a visit, and then the 3 steps of the fall prevention care planning. So identifying and confirming risk factors, confirming the recommendations or editing as they see fit, and then documenting, print, and sharing the care plan with the patient. The facilitator only gave hints related to system use if participants were unable to complete the step or if an error would have prevented the completion of the next step. We used the single ease questionnaire to measure perceived difficulty at the completion of each task during the first scenario, and this helped us this provided some insight into the potential differences in usability between the 4 different tasks. And then after completion of the second scenario, we used the system usability scale using a polling feature. To assess learnability, we measured time on task, hints. We looked at for errors between the first and the second scenarios. We also asked some open-ended questions to determine what the PCPs liked and what they didn't like about the tool, if they preferred it to their current fall prevention practice, and if they would recommend it to others. We also completed summative testing after go live, where we conducted clinic observations during the first 6 months. We measured acceptability, reviewing recommendations that were presented to each participant and those that were included in the final fall prevention plan. We also measured provider perceived usability at the live sessions with the Health I2s and the patient perceived patient provider trust and shared decision making. So we completed 14 summative usability test sessions and then 21 clinic observations. The mean percentile system usability scale score during the summative usability sessions was 81 out of 100, indicating above average usability. Most participants said that they would recommend Aspire to a colleague and they preferred Aspire to their current practice. Participants rated tasks as relatively easy, with the mean single ease question ratings for the different tasks ranging between 5.1 and 5.5 out of 7. We saw significant improvement in learnability where with the first scenario, it took on average 13 minutes, the second took on average 9, and then during the real encounter workflow observations, providers spent an average of 4 minutes using the tool. On average, the number of hints decreased from the first scenario where on average we provided 2.6 hints down to less than 1.14 for the second scenario. In terms of acceptability, we found a lot of variation by risk factor and recommendations category. So, for example, the exercise recommendations were accepted in the majority of the usability sessions and also in the by the observation participants. Only one participant felt that the exercise was not applicable. Acceptance of the FRID-related recommendations was mixed. Some of the medication recommendations and handouts were accepted, but providers told us that deprescribing was a process, that it could be started during a visit, but it would most likely take several visits to get the patient to agree and then to get them to actually get to the tapering or the discontinuing of the medication. The least accepted recommendation was the prescription of bisphosphonate. So this recommendation was accepted only by about half of the providers that saw it recommended for their patients. We also in the live sessions, we used the I2s for usability. The median usability was 4 out of 5. The patient rated provider trust and shared decision making as high. And then in the triangles, these are the 4 themes. These are 4 key themes that we found in the post-pilot interviews that were then used to identify the list of future enhancements. So the first was access. So providers wanted easy access to the Aspire tool within their EHR workflows. PCPs at the rural site were really satisfied with their ability to access the tool directly on the fall risk assessment module that they completed during every primary care visit. At the urban site, providers had some difficulty remembering where this Aspire tool was located. We had linked it to a fall risk icon that was in every patient's record that was at risk, but they weren't used to using it for that purpose. So they had recommended that we integrate the tool into the commonly used health maintenance area of the electronic health record. In terms of context and barriers to use, most providers reported using the Aspire tool during a Medicare annual wellness or annual visits on older patients who had a previous history of falls or balance problems. They reported that these types of patients, though, often have many comorbidities and that are very time consuming to address. And this could be a barrier to actually spending enough time related to fall prevention, along with everything else that needs to be covered in that visit. Providers reported that Aspire helped them to engage patients in fall prevention, that it was helpful for convincing their patients to make changes. They also found that using Aspire during a patient visit helped to motivate some patients by bringing up the discussion and highlighting the importance of fall prevention. And then providers expressed several positive perceptions of value of the tool on their decision making, on patient discussions, and as a teaching tool. And some providers mentioned that it prompted more physical therapy referrals. It reminded providers to have discussions about high-risk medications, bone health, and exercise. So fall prevention decision support today is lacking in primary care. Aspire provides evidence-based CDS that integrates into clinical workflow. It's highly rated by providers and patients. It's interoperable with different EHR systems. Aspire targets common fall risk factors that can be addressed in the context of a visit. We did hear that some risk factors like FRIDS need to be addressed over multiple visits, but having decision support like we offered in Aspire can help get the conversation started. And it does provide patients and providers with some actionable tools that can be used during those visits. Providers and provider and patient-facing tools that are integrated into the software can be shared with the patient during a visit or with the patient's after visit documentation. In our implementation in the urban site, the EHR was able to include the care plan and all of the content in the patient's after visit summary that was automatically generated. In the rural site, they didn't have that functionality, so they were printing the discharge documentation or the end of visit documentation, and so that's how they provided this content as well. We chose to save the fall prevention plan to the EHR, share it with the patient, and hope that it would continue the conversation with the patient and the family. We have included the Aspire shareable event condition action rules via the CDS Connect website with this project. And as in the past, we found that participatory design approach is quite useful. It integrates multiple usability evaluation methods into each stage of the project. We included talking points and patient and provider tools in Aspire. And we found that engaging patients in fall prevention as part of the visit is a new workflow for many providers. And so provider recognition of the value of engaging patients in this way, and also the use of Aspire and other health IT tools to engage patients does have impacts on workflow, and more work is needed in this area. We found that we had to pay attention to clinician readiness and logistical skills as part of the training and the rollout. Implementation is not without real world challenges. We stuck to our principles, which is that true stakeholder involvement is really needed in designing the data, the information, the workflows. And that does help with overcoming some of the obstacles. So I'd like to acknowledge the Aspire team from Mass General Brigham and my co-PI Robert Lucero and his team from the University of Florida, and our advisory council, which was a group of experts from informatics, primary care, geriatrics, and fall prevention. And this is my email address, so if you don't get the questions answered that you'd like to ask today, please feel free to email me. Thank you, and I'll turn it back to Mario.
Thank you, Dr. Dykes, for sharing your tremendous work. As a reminder, we'll be taking questions after all presentations, so please submit any questions you have using the Q&A panel. Our second webinar presentation will be led by Dr. Alex Baropoulos. Dr. Sparopoulos is a professor of medicine at the Zucker School of Medicine at Hofstra Northwell and the system director of anticoagulation for clinical thrombosis services for the multi-hospital Northwell Health System in New York. He is also a professor of the Institute for Health Systems Science as part of the Feinstein Institutes for Medical Research. Lastly, he is co-chair of the Council on Leadership of Thrombosis at Northwell Health System. Dr. Sparopoulos has helped to develop protocols using low molecular weight heparin in outpatient-based treatment of venous thromboembolic disease, patient self-testing of warfarin, and preoperative bridging for patients on chronic anticoagulation, as well as medical inpatient and extended thromboprophylaxis. And now allow me to turn control over to Dr. Sparopoulos.
Thank you, Mario, for that nice introduction. And again, I'd like to thank the Agency for Healthcare Research and Quality for their kind invitation for this important webinar on transforming guidelines into action. I will be discussing the development, implementation, and impact analysis of an electronic health record agnostic clinical decision support tool using a specific venous thromboembolism or VT-CDS tool, namely IMPROVE-DD, as a case study. I will be discussing this from the point of view of a clinical trialist and thrombosis expert with some informatics experience. Learning objectives, as we saw earlier, to identify new modalities for CDS development and implementation that offer true vendor-agnostic capabilities, such as service-oriented architecture that are capable of fast healthcare interoperability resources or FHIR standards. Also conducting a large impact analysis using a cluster randomized trial design to test CDS implementation of a specific VTE risk CDS tool. By way of introduction, the practice of evidence-based medicine at the point of care has well-established benefits, particularly when it is implemented in the form of software-based clinical decision support that has been smoothly integrated into clinical workflows within electronic health record software systems. Previous work by our team, funded by an AHRQ grant, included the conceptualization and development of Evidence Point, which is an EHR-independent CDS software that is capable of being integrated into clinical workflows within various EHRs at various clinical sites without requiring the solutions to be rebuilt for each deployment. This would make it easier to create and disseminate software-based CDS solutions that help promote the practice of evidence-based medicine at the point of care and also has potential to incur high adoption. The VT risk assessment of hospitalized medical patients using a validated risk assessment model or a clinical prediction rule represents a classic test case of use of our EHR-independent CDS platform. This is a heterogeneous population with varying risk of VTE, and studies reveal consistent over-prophylaxis of low-risk patients and under-prophylaxis of high-risk patients, potentially incurring patient harm. Now, we've known from both clinical studies and randomized trials that the use of health informatics technology in the form of electronic or human alerts have potential to increase appropriate thromboprophylaxis in at least in one trial, reduce thrombotic events. But in this older informatic era, there were limitations of using electronic alerts in passive systems, which included operator fatigue, the lack of interoperability among EHRs, and major resource utilization, including human and IT resources. We now live in a very different health informatics environment with the potential for CDS tools to live in an EHR agnostic environment using smart HL7 FHIR standards or smart on FHIR-like standards, depending on the EHR system, as many of us are aware. Now, historically, there's been a natural tension between CDS tool integration versus dissemination in a particular EHR environment. CDS that is tightly integrated is likely hard to disseminate, and conversely, CDS that is easy to disseminate is likely loosely integrated into an EHR. The innovations by our group was to create a platform for CDS that was both tightly integrated as well as easy to disseminate, as we can see depicted in Circle C here. An overview of how we did this with respect to our Evidence Point platform EHR integration is shown here. The particular EHR is shown on the light blue and the Evidence Point platform on the dark purple on the right. When a user launches a particular CDS tool from a typical EHR workflow, the tool is or the tool is triggered automatically. The launch request then goes into play, which includes the patient's visit-specific ID. The CDS tool forwards the request to the Evidence Point Application Programming Interface, or API, which then retrieves the patient data from the EHR data backend and pre-populates the tool with patient data where possible. The user is also able to fill in any remaining information as the tool calculates a personalized risk score for the patient, which in turn is then sent back to the EHR to be incorporated into the patient's medical record, as well as trigger any resulting next steps in the EHR, such as opening an order set. An example of an integration of our Evidence Point platform in an external health system is depicted on this slide, where we see on the left a particular EHR front end as well as EHR data backend, which includes multiple EHR affiliates and a health informatics exchange system, and our Evidence Point platform on the right, including multiple points of connectivity using this 6-point approach that I earlier described. And this slide shows the integration of a particular CDS, the improved VTE model that I will be discussing shortly. And we can see here how the Evidence Point platform structure Both encourage front-end interfaces as well as back-end data systems exchanged within our systems, EHR, which was all schools. Now, after integration, we also had to assess implementation outcomes. And towards this, we used Proctor's methodology, which looked at 6 implementation outcomes. The primary outcome was tool adoption, then tool acceptability, appropriateness, feasibility, tool fidelity or delivery as intended, and tool penetration or reach. The data collection time points included all post-implementation time points. The data sources included both EHR as well as survey sources, and the measures were tool-specific. For the primary endpoint, which is tool adoption, we used the proportion of providers at discrete time points that used greater than 60% of opportunities for use using the improved review tool, as we'll see shortly. We also had to establish usability outcomes, and towards this end, we have now a very mature usability lab at Northwell and Feinstein's, and we looked at 5 usability outcomes that you can see here: user success rate, user error rate, time on task, overall usability, and design feedback. Looking at testing rounds that include think aloud, near live, and live, data sources that include visual reporting of tool use or surveys and transcripts, and again, measures that were tool specific. And lastly, on top of everything, we had to incorporate our existing CDS tool on a quite sophisticated informatics architecture that existed in our system for VT prophylaxis, as shown in this quite busy slide. Our informatics architecture included biometrics, lab values, relevant results, as well as relevant patient populations, such as medical versus surgical patients for VTE prevention. So this, again, superimposition was quite complex in terms of ultimate tool implementation. Now, when choosing a tool for our platform, we chose clinical prediction rules that have undergone broad validation, which means that an application of a specific clinical prediction rule was used in multiple clinical settings with varied prevalences and outcomes of disease. In other words, a level of evidence 2, as shown in the seminal work by McGinn and colleagues. The ultimate holy grail of tool validation is that of a formalized impact analysis, where there is clear evidence that a specific clinical prediction rule not only changes physician behavior, but also is able to improve patient outcomes and or reduce costs. It's important to note that there are actually very few cardiovascular clinical prediction rules that have undergone formalized impact analysis. We've also lastly spent some time constructing what an idealized risk model or clinical prediction rule for DVT prophylaxis would look like in medical inpatients. This tool would enable clinicians to accurately identify patients who meet a threshold risk of developing a thrombotic event in the absence of prophylaxis, be able to predict the correct risk level using both disease-specific and predisposing risk factors for thrombosis, which would allow more tailored thromboprophylactic strategies, reliably exclude patients without a beneficial risk-benefit ratio, be evidence-based and validated, methodologically transparent, and simple to use in clinical practice. We now have a wealth of longitudinal data that tells us if we use an intuitive approach for thromboprophylaxis without evidence, we are likely overprophylaxing as much as 65% of low thrombotic risk patients and subjecting them to the harms of pharmacologic thromboprophylaxis, usually bleeding, and likely underprophylaxing as much as 25% of high thrombotic risk patients by giving them inadequate durations of thromboprophylaxis and thus subjecting them to the harms of a thrombotic event. Now, the tool that we chose for our platform was the improved VTE tool shown here. We derived and developed this tool over 13 years ago, and at this point, it is the most widely validated tool of VT prevention in this population, validated in over 100,000 patients globally and endorsed by multiple anti-thrombotic guidelines. On the right, we see the actual model itself, which is made up of 7 clinical risk factors that are weighted and scored from 1 to 3 points. And more recently, we also included a novel biomarker, an elevated D-dimer, to improve model discrimination. And on the lower left, we see the model thresholds or cutoffs for the tool itself. So a score of 0 to 1 predicts a low-risk population that does not benefit from inpatient thromboprophylaxis. A score of 2 to 3 predicts a moderate thrombotic risk population that benefits from in-hospital thromboprophylaxis, usually with a heparin-like agent. And a score of 4 more predicts a high VT risk population that benefits both from in-hospital as well as extended post-discharge thromboprophylaxis, usually with a direct oral anticoagulant such as rivaroxaban. Now, after multiple iterations, this is what the final improved DBVTE CDS tool looked like within our system. This is a screenshot of the final product. As we can see, when the improved DD tool was launched, the answers to the yes, no clinical and laboratory risk factors were pre-populated based on existing patient-specific data in the EHR or HIE environment. The user was also able to manually adjust the individual risk factors as needed as well. When the user clicked calculate probability, the improved VD score and the 3-month VTE risk percentage was displayed, with low risk in green, moderate risk in yellow, and high risk in red, as we could see. And then finally, when the user clicked record results and proceed, the tool closed, the improved VD score was written to the EHR, and very importantly, an actionable item, namely an appropriate prophylaxis recommendation, was displayed in the EHR. After we finalized the CDS tool, we then undertook multiple iterations with our usability lab in terms of optimizing the workflows that the tool should be launched from. And ultimately, we assigned 3 workflows for launching the tool. First one seen here is in the VT prophylaxis order set. So when a provider opens the VT prophylaxis order set for medical patients, there's a dedicated button when checked and launches the improved VT tool. The second workflow was the history and physical workflow. And again, when the provider searched for and created a new adult history and physical note, there was a dedicated tab in the Create tab to launch the improved VD tool. And the third workflow represented a brand new workflow, namely an at-discharge workflow, where we created a brand new button on the discharge note to launch the tool itself. And depending on the threshold score achieved, in this case, a score of 4 more, a recommendation for post-discharge VT prophylaxis was made, and then the circle was closed during the medication reconciliation process. Now, we were able to successfully implement this tool into the workflows described into our Northwell Health Systems hospital. But then we wanted to test the effectiveness of the tool itself in a formalized impact analysis of how it would fare against usual medical care. And towards this end, we received funding from a pharmaceutical grant to conduct a large cluster randomized trial to test the effectiveness of the improved VD tool versus usual medical care in a formalized impact analysis. And we presented the primary results of this trial as a late-breaking clinical trial abstract at the American Heart Association meeting in November 2022. We conducted a clustered randomized trial at the level of hospital, and we chose 4 academic tertiary hospitals within our Northwell system based on historical medical inpatient admissions. We randomized 2 hospitals to usual medical care and 2 hospitals using this CDS tool at the 3 workflows that I've already mentioned. Outcomes were measured up to 90 days post-discharge. The primary endpoint of the trial were the rates of appropriate thromboprophylaxis based on the predefined score threshold, either score 2 to 3 for moderate risk or score 4 more for high risk. But importantly, we actually powered the trial for major secondary endpoints, which included hard outcomes such as major thromboembolism and major bleeding at 30 days. We conducted this trial from December 21, 2020 to January 21, 2022, during the throes of the COVID-19 pandemic in the New York metropolitan area, making this an exceedingly difficult clinical trial to conduct. Nonetheless, we were able to randomize nearly 10,700 medical inpatients, including approximately 23% of patients that were hospitalized for COVID-19. And the primary outcomes of the trial are shown here. Our CDS tool adoption rate approached 78%, which is quite high when comparing them with historical tool adoption rates of about 10 to about 30% seen in similar CDS environments. Our trial achieved its primary outcome and showed a significant increase in appropriate in-hospital prophylaxis in the intervention group versus control group from 72.5% to 80.1%, which represented a 50% relative or an approximate 80% absolute increase in the rate of in-hospital prophylaxis. Also, just as importantly, for high VT risk patients, we achieved significant increases in appropriate at discharge extended from prophylaxis in the intervention group as well, from 7.5% to 13.6%, representing a nearly 100% relative increase on approximate 6% absolute increase in appropriate prophylaxis. When looking at the rates of prophylaxis in the control group, they are quite high relative to non-academic and non-tertiary care centers. So we expect these results to be more robust in settings other than non-academic tertiary settings. And lastly, in terms of secondary outcomes, for the first time, we were able to show that our CDS tool was able to reduce AHRQ outcomes. For VTE, or venous thromboembolism, which comprised of deep vein thrombosis and pulmonary embolism, we showed a 20% relative or 0.6% absolute risk reduction in the intervention group versus control group from 3.3% to 2.7%. For arterial thromboembolism, which included stroke, myocardial infarction, and systemic embolism, we saw a 65% relative or approximately 0.5% absolute risk reduction from 0.7% to 4.25%. And for total thromboembolism encompassing both, we saw 29% relative or 1.1% absolute risk reduction from 4% to 2.9%. Major bleeding was rare and did not differ between groups. All-cause mortality was paradoxically elevated in the intervention group, but further analysis of the data revealed that this was due to an outlying hospital in the intervention group that admitted more patients with COVID-19 due to restructuring and redeployment-related issues around COVID-19. So to conclude, our study has major health system implication, as it has shown that a novel universal platform agnostic tool for clinical decision support for VT risk assessment that is integrated into clinician workflow not only demonstrated effectiveness in increasing adoption of evidence-based practice with an adoption rate approaching 78%, but importantly, significantly increased both appropriate thromboprophylaxis and significantly reduced hard outcomes in venous and arterial thromboembolism in hospitalized medical patients. Our study has important populational health implications when we keep in mind that there are over 8 million medically ill patients that are hospitalized each year in U.S. health systems that are at risk for a thrombotic event. So what are future directions of our study? Well, we hope to engender widespread implementation of the improved VTE CDS tool on our evidence-based EHR agnostic platform. And towards this end, we partnered with 3 other health systems in the large Common Spirit Health Network that have different EHRs, namely Cerner and 2 instances of Epic. And we formally applied for an R1 grant through the AHRQ mechanisms of dissemination and implementation research and hub. Thus, we hope to further refine the CDS tool as well as usability testing and evaluate usability and implementation of the CDS tool in different EHR environments, as well as evaluate the use of evidence-based thromboprophylaxis and develop shareable CDS artifacts. With this, I'd like to conclude by acknowledging the Department of Medicine at Northwell Health, and especially my partner in the project co-PI, Tom McGinn, who is now at the Department of Medicine at Baylor College of Medicine, and who has been instrumental in creating the Evidence Point platform. Also, the Institute of Health System Science as part of the Feinstein Institute for Medical Research, especially Jeff Solomon, who heads our usability lab. And lastly, the Biostatistics Unit Office of Academic Affairs at Northwell Health. And lastly, I'd like to thank you all for your attention. This is my contact information should you have further questions, which I welcome. Thank you very much.
Thank you, Dr. Sparopoulos, for sharing that exceptional work. Again, feel free to submit any questions you have using the Q&A panel at this time. We will try to answer as many as we can at the end of the presentations. Our final presentation will be led by Dr. Kensaku Kawamoto. Dr. Kawamoto is a professor and vice chair of clinical informatics in the Department of Biomedical Informatics at the University of Utah. He is also the associate chief medical information officer and director of the Reimagine EHR initiative, which is a multi-stakeholder initiative to improve patient care and the provider experience through interoperable EHR apps that convert data to actionable insight. Dr. Kawamoto is also the co-director of the University of Utah's Digital Health Initiative, a member of the U.S. Health IT Advisory Committee, and co-chair of the Clinical Decision Support Work Group of the HL7 Standards Development Organization. Today, he will be describing his AHRQ-sponsored research to improve lung cancer screening through EHR-integrated CDS and shared decision-making tools. And now I'd like to turn control over to Dr. Kawamoto.
Thank you very much, and thanks everyone for sticking on an hour into a webinar. Thanks for that, and nice to see familiar names in the folks attending who I know work on this kind of stuff, so really glad to be sharing with you today. Okay, so I'll be talking about our AHRQ-funded project to improve lung cancer screening through an EHR integrated what we call everyday shared decision-making tool, along with clinician-facing prompts. So in terms of the bottom line impact, this research that we'll describe, I think showed that you can have a shared decision-making tool that you really can integrate into clinical practices and combine that with clinician-facing prompts to significantly improve screening for lung cancer. And this is important, as I note, because it's by far the leading cause of cancer deaths in the US and around the world, even though a lot of other cancers, I think, get more recognition. Disclosures, as was mentioned earlier, I do some outside work, but with regard to this particular work, I have no conflicts with direct relevance. And of keynote, everything I'm going to share today is available for free, and we are actually actively disseminating it with AHRQ support. So if you're interested, we would love to share not only the research, but really the work products and to actively support that. And this work was made possible by AHRQ. Okay, so just in terms of clinical background, lung cancer, it's the #1 cause of cancer deaths in the US for both men and women. It's about 1 in 5 all cancer deaths and about 127,000 deaths estimated for 2023. So when I got into the space, I did not know because it gets so little attention compared to things like breast cancer and colorectal cancer, but it's kind of sobering how important this cancer is and yet has relatively little public recognition. At the same time, there's been landmark studies showing that you can catch lung cancer pretty early at a more treatable stage using low-dose CT scans for lung cancer screening, and it can reduce lung cancer deaths by about 20%, so pretty substantial intervention available. The USPSTF recommends offering screening to high-risk patients, that is, older patients with a history of heavy smoking, for 10 years now. And the criteria for PACURE, as you can see there, has changed a little bit between 2013 and 2021. But essentially, you need to be an older adult with a substantial smoking history and be a current or recently quit tobacco user. Now, interestingly, you look in the vast majority of eligible patients in the US are not screened. So in 2020, the nationwide screening rate was 6.5% and less than 2% in Utah. So you can just imagine if, say, breast cancer screening rates were 6%, what kind of outcry we'd have. And this has, so far been accepted as sort of status quo in what is the leading cause of cancer deaths. So really something that needs to be addressed. Now, there's a number of barriers with regard to provider barriers to screening. One is lack of familiarity with eligibility criteria and insurance coverage, also difficulty identifying eligible patients. Even though the mortality burden is really high, you actually have to smoke a fair amount. So for a typical primary care provider, it's not that many patients you have in your panel that have this. So it's not like, something you see every day, and makes it so that you need support to identify eligible patients. Management of screening results is also a concern. Some skepticism about the benefits of screening, which is kind of hard to understand too, because it's actually much more effective than a lot of well-accepted modalities of screening. And a key one we focused on was insufficient time or knowledge to conduct shared decision-making. So lung cancer screening has actually some important potential downsides, like if you see something suspicious, you want to biopsy it, and it's the lung, so you can have complications like a collapsed lung and even death. And there's also, it's rare, but it can happen, and there's wide individual variation in expected benefits. So if you look at the original national lung screening trial, if you divide people's risks by 20 percentiles, the top 20% versus the bottom 20%, there's about a 60-fold difference in expected benefits. So you can imagine that's pretty wide individual variation when you're talking about whether it's right for you. And the shared decision-making is recommended by clinical guidelines, and it's actually the only one right now by CMS it actually is required to be conducted to get paid according to their payment guidelines, and you need to use a decision aid. So it is a barrier, especially for quite complex patients who almost certainly tend to have many more things going on than just lung cancer screening as a need. Let's see, next slide. Okay, so the objective here was to design, develop, and evaluate a widely scalable approach to enabling lung cancer screening that addresses these key barriers to screening. And these were our intervention goals. So first, we really wanted to integrate into routine primary care workflows. And this is because most care occurs in primary care. And if you look at, the widely used cancer screening procedures that have high adoption, like breast cancer screening, cervical cancer screening, colorectal cancer screening, part of the key to success is it's just a part of primary care, right? Like it's just something you expect to talk about with your doc for your primary care visits. So we wanted to integrate it there. We wanted to make it easy for providers to identify who's eligible, right? Because again, it's not many patients who meet these criteria for typical panels. And we wanted to make it easy and fast for providers to conduct a shared decision-making. So we want to support, I'll describe a little bit later, an everyday shared decision-making approach that you could incorporate, into just a part of everyday patient care that could be completed ideally within 1 or 2 minutes, while allowing what we call full shared decision-making when the time is available. So this was really key, given that patients typically have a lot going on, and we want to use an approach that can be widely scaled. So just a quick note here, this work is based on our co-investigator, Tanner Caverly, who's been really instrumental in this work from the University of Michigan, who's proposed this notion of, shared decision-making, it's a good thing, but it takes a lot of time. So how can we get it incorporated better into routine workflows? So I'd say the right one, the full SDM, is what's typically talked about with shared decision-making, something that takes 3 or 5 minutes or more. And it doesn't sound like 3 to 5 minutes is too big of a deal, but actually in primary care workflows, it's a lot, right? Just for the initial presentation. And the notion here is that you do a quick initial presentation that's highly tailored, and you do actually provide a recommendation for the patient, and you support the patient autonomy, but you basically go in with saying, this might be the situation with you, what do you think? Rather than just provide information, sit back and wait for the patient to sort of decide based on the data without guidance. So with this, a key starting resource we had was a tool called Decision Precision that was developed for lung cancer screening, a web-based tool developed by Tanner and Dr. Andrew Fagerlin at the University of Michigan and now at the University of Utah. And this was originally designed to support what we call the full SDM approach. So what they did was they had full-time lung cancer screening coordinators in the context of dedicated lung cancer screening shared decision-making sessions at the VA. And they used this tool and, it worked well there, right? But it was too time-consuming to use routinely in primary care settings when we looked to bring this into primary care. So you can see here, for example, up top, there's a whole bunch of tabs, and the notion there was you would go through each tab and sort of talk about each topic with the patient. Great for a full discussion, but as you can imagine, hard when it's like, item number 9 and, 9 problems that you have to address during your 15-minute visit. So what we did as part of this project was first to just update and enhance this tool for everyday shared decision-making. So this is a screenshot. It's available for free at screenlc.com. You can go right now and check it out. So the only elements needed for sort of the everyday shared decision-making model was kept on the main web page. And then all the other sort of supplemental content was moved onto the other tabs. So you can still do everything that the original tool would want to support, but it's sort of been compartmentalized. And I'll talk about it in the next slide, but it has a lot of time-saving features. And if you use Epic, for example, this tool is part of now what's linked to from what Epic's foundation workflow is, which is sort of the default build of Epic that you get or can update to. So, so we're glad about that. And then this is the EHR integrated version, which we call Decision Precision Plus. And again, all these are free. So this is integrated with the electronic health record. This is showing it in action in the Epic EHR. So just to sort of go to where those points are, I'll just note that this figure and a lot of the data are from a chess paper that you can already find online as well that just recently came out. So you can see with that item 1 that where it says personalized risk assessment, it's basically one tab, right? You can do everything in that one tab and move on. You can always go to more, but you don't have to. You can see with item 2, we do look at the patient's risks and benefits and try to help with that, like bottom line, is this something where like no brainer, you should get it done, right? Or is it more preference sensitive and you have to think about it a little bit more? Under number 3, we have a document shared decision-making button that auto-generates a pretty extensive patient-specific documentation to meet CMS requirements that we worked on with our compliance folks. Number 4 shows a 30-second example script that you can use to just very quickly in a patient-specific way sort of talk through sort of where they are and what might be relevant. Number 5 just shows that this is just part of Epic, just another tab that's available. Number 6 shows that we're pulling in a lot of data. The latest model actually pulls in something like 23 factors from the patient record that just gets snapped up using the Smart on Fire mechanism. Number 7 shows that you can actually order screening directly through this interface. And number 8 shows where you can document in the record things like the patient decided to screen or decline screening. And that actually makes further updates into the EHR that will drive other workflows like follow-up for screening and things like that. Okay, so you got to get to this. These are some of the ways we prompted for this, this topic. So under number 1, you can see, it's a little bit hard to see, second from the bottom for those care gaps you see is lung cancer screening discussion. So if you haven't had a discussion before, we start by prompting for a discussion in what's known as the health maintenance module in Epic. And if you decide to screen, we move on to remind you to get your annual screening. Number 2 shows this, when you click on sort of that number 1 section, it'll open up this health maintenance section. Number 3 shows this topic for lung cancer screening discussion. With number 4, it's really hard to read, but it's basically a hover over that says, hey, like CMS requires shared decision making, you got to use this app. So we provide that there. Here's another place. When you try to order lung cancer screening, we prompt for this. So number 1, this is in the lung cancer screening ordering screen. Dynamically, if we detect that you have not done the required shared decision making, we'll put a note saying, hey, you got to do this if you want to get paid, with a button that you have to, a forced acknowledgement. And then we also provide this information in the processing instructions as well. We hadn't done these in the trial I described, but there's other ways you can integrate this into your EHR, and this is Epic use cases. So you can put it in alerts and reminders with the direct link to launch this shared decision-making tool. So for example, in Epic, best practice advisories or BPAs, you can do this. And you can be, and this can be tailored to only fire, for example, or to fire differentially for the highest risk patients. So that's something we've considered. We haven't done that at our health system, but certainly is technically feasible. You can also directly link to launch the app from what's known as the care gap closure workflows. So in Epic, for example, if you practice, you probably use the closed care gaps order sets. You can now directly link from there to open these apps. And we have since implemented that in our health system. Okay, so we conducted a pragmatic clinical trial to look at the effects of this. This was done in 30 primary care and 4 pulmonary clinics at University.Health. And our interventions included EHR prompts, like I showed you, and the EHR integrated everyday SDM tool. It was a pre-post analysis. We did that because we couldn't randomize the health maintenance components. In Epic, it's an all on or all off kind of deal. We had a waiver of consent from IRB, We focused on primary care patients who met the 2013 criteria because that was the one that was enforced throughout the study period, who didn't have a chest CT in the past year and who had not declined screening in the last 3 years. So basically someone who we felt should have shared decision making and initiated on screening if indicated. So the primary outcomes were whether they ordered screening, whether it was completed, and follow through, which is essentially if we ordered, did they complete the order test? Was the logistic regression with mixed effect models, covariate adjustment, and we did subgroup analyses to look for things like did it matter depending on your benefit level expected. So these are the results. 1,435 patients were included in the study. Low-dose CT ordering increased for eligible patients from 7.1% in the pre-period to 27.3% in the post-period. So it's an adjusted odds ratio of 5. Pretty strong. We oftentimes in CDS are happy with seeing like a 10, 20, 30% increase. And this was like a 4-fold increase. So that was pretty strong. Low-dose CT completion also increased with an adjusted odds ratio of 5. We didn't see a change in the order follow-through rate. That is, like once we ordered it, that the patient, complete it. But that's an area for future enhancement. Subgroup analysis-wise, we found that the ordering and completion was actually higher in high benefit patients. So patients who we estimated had a much better likelihood of benefiting substantially from the screening compared to what we called intermediate patients. But it was marginally significant, not reaching p less than 0.05. Interestingly, in the pre-period, patients that were only seen in primary care, so weren't also seen by a pulmonologist, were significantly less likely to be screened. So it was a 6.3% screening rate there versus 15.6% in the pulmonary clinics. But after we turned on the intervention, it normalized. So primary care clinicians, it was 27.1% versus 29.7% when they were seen in pulmonology. So I think pretty promising there in terms of primary care integration. We did find improvements across demographic subgroups, sex and race ethnicity. So for example, for our Black patients, screening went up from 6% to 30%, which is important too because lung cancer screening is known to, in particular, affect Black patients because they're at higher risk given otherwise similar smoking histories. And then interestingly here with the shared decision-making tool, it was used prior to low-dose CT ordering for about a quarter of patients, about 27% for high benefit patients and 21% for intermediate benefit patients. Of course, we'd want it to be 100%, and I'll comment on it. But given how much time it takes and what the literature on how often shared decision-making tools are actually used in practice, we're pretty happy with it. Definitely want it to be higher, but it was pretty good. This just sort of visually shows what this looks like. So this is the on the top, the ordering rate for lung cancer screening for eligible patients, and the completion rate on the bottom one for the high benefit patients in red and the intermediate benefit patients in blue. And you can see there's a clear change. And we don't have this published yet, but we have an upcoming subsequent analysis showing the trend just keep continuing. So it's going up and up. And we also found that even simple patient reminders has a pretty substantial impact on getting patients engaged and getting screened as well. So just in summary, when we introduced this EHR integrated everyday shared decision-making tool, and provider prompts, we found significantly increased ordering and completion of lung cancer screening at a single health system, so adjusted odds ratio of 5, which I think is pretty excellent. Shared decision-making tool use was about 25% prior to initiating screening. So as I showed, we did provide multiple prompts in the EHR to use the shared decision-making tool, but clearly it wasn't sufficient to get it higher. This was suboptimal, but when you look at the literature of previously reported shared decision-making and shared decision-making tool use rates in primary care settings, and not like a study focused on trying to get people to use shared decision-making, but just seeing what happens in the wild, it's actually pretty decent. A lot of times it's pretty low. And I'll note our rollout, we just use typical IT rollout kind of techniques. Like, we sent out a notice that it's available, and that's pretty much it. And we know, for example, like a lot of our providers just don't look at the emails we send from the IT department to say, hey, this is coming in your next Epic release. What we've heard and makes sense is that even a few minutes may be just too much to add to busy primary care workflows. And you just go into look at these patients and their charts, and they have a lot going on, right? Like you could have had a stroke, a month ago, and you're doing a follow-up visit, or you have like 6 conditions, including COPD and cancer and all that kind of stuff. And it's a challenge, right? To then say, let's do shared decision making for a prevention issue. And we did consider more stringent approaches to requiring use of the shared decision making tool. Like we certainly could have placed things like hard stops in the system, so that if you didn't use the shared decision making tool, we would prevent you from ordering a test. But we decided, doesn't make sense. Like people might take that as too much of a burden, and appropriate patients could not get screened. So we really wanted to avoid getting the situation where we put up too much of a barrier just so we wanted folks to use our tool, and in the end ended up harming patients. Current research focus-wise, we have another AHRQ grant. Thank you, AHRQ. Where we're doing a few things. One is we're validating a replicable approach to real-world dissemination and implementation of these kinds of tools. So the web-based version of obviously just free on the web. The Smart on Fire version, it's available for free. We can integrate with any EHR. We've successfully integrated with multiple, including we have a Cerner integration going on with Intermountain Healthcare. We are integrating with the VA. And we have multiple implementations underway. It's free. We'll provide free integration support. And this is what AHRQ is sponsoring us to help do. So if you're interested, please contact us at reimaginehr@utah.edu. And we have all sorts of implementation support and self-help guide and all that kind of stuff. And we think we can get this into a pretty quick installation. So if you're interested, please let us know. We're also working on designing, developing, and implementing interventions to directly engage patients and overcome some persistent barriers to lung cancer screening. So this is getting at the fact that I've spent most of my career working on provider-facing clinical distance support tools, and we're happy if we see like a 10, 20% relative increase in things, right? And by golly, here we saw a 5-fold increase, like 500% kind of thing, right? So we should be super happy, but it still is, to me, kind of crazy that you have something, for example, is the #1 cause of cancer deaths, right? Over 100,000 people dying every year from this, and the fact that it might take a minute or two to discuss means like things don't get done. So we think, let's get this in front of patients. Like the assumption here is that most patients, myself included, would prefer to spend 10 minutes working on something than to not get something because their doctor didn't have a minute or two to spend, discussing something because they had so much on their plate. So we're developing this Smart on Fire tool. It's actually already developed, called My Lung Health. It's a free patient-facing Smart on Fire tool that's integrated with the PHR to educate and activate patients. No download needed, as far as you can tell as a patient. It's just part of your, personal health record, like pre-visit check-in kind of process. We're engaging patients also via the patient portal to address missing, stale, and inaccurate smoking history, which we found is rampant. Data is oftentimes missing, never gets changed, and that's obviously has huge implications. We're working with NYU here to do a patient randomized trial, and we'll also be sharing this part following our validation. So for more information for the web-based version, you can just get it at screenlc.com. And the Decision Precision Plus tool, if you're interested, please contact us at reimaginehr@utah.edu. Again, it's free, and we're supporting the implementation, so like really free. And you can see there's a paper here. We're really excited to get this into CHEST. So available results from the clinical trial. And we have another paper on our overall Reimagine EHR initiative, where we've done a ton of work on things like Smart on Fire CDS hooks where this is one of many, and lots of folks working on these projects. Just to acknowledge the top grant there was what funded this work, and thank you for our project officer, Dr. Roland Gamache, who helped us through this. and the current one with Dr. Taran, who's helping us through with the current project, and a number of collaborators right here. Thank you very much, and I think I just have my contact info. Thanks.
Thank you, Dr. Kawamoto, for sharing your inspiring work. And thank you again to all of our brilliant presenters for their very informative presentation. A reminder, please submit any questions you have for any of our presenters using the Q&A panel. This concludes the content portion of the webinar. Now we have a few minutes left for questions. You can type them into the Q&A section of the WebEx portal. Although we may not be able to get to all of your questions today, we will provide responses to all questions in writing. You'll receive an email once all these responses are available. To begin with our panelists, as a broad question, who is responsible for the continued maintenance and updating of these CDS tools? And is there a business model to continue to support these projects for the foreseeable future? We'll begin with Dr. Dykes.
Yeah, so right now we have started working with our innovations office on that, but I think that's a problem with many of us researchers is we think about, how to get the, we think about how to design the CDS and how to make it so it really fits beautifully in the workflow and looking at that. But then when it comes to, what is the business plan for the future, we've done less around that. So, but we have started meeting with our innovations office and we are working on that.
Thank you, Dr. Dykes. Dr. Spiropoulos.
Yeah, I'd have to agree that the hard part, really, the easy part sometimes is in creating the CDS and creating it as perfect as you can. But the real difficult part is the maintaining it, over time. And how do you do that? So much like Patricia said, we also are working within our innovations lab group, as well as some of the key informatics component to see how we can, extend the CDS and then expand it to places, for example, like the Epic App Store, where, in theory, there could be a commercial component to these tools, even if they're available freely. They could be tweaked, especially and implemented in certain ways. But I think, going from an academic research model to a maintenance and commercialization model is problematic.
Thank you, Dr. Spiropoulos. Dr. Kawamoto.
I'd say we're fortunate because we're also part of the health system operations. In general, we build everything with the intent to keep it running and to operationally maintain it. I mean, it does mean you get a call at 3 a.m. that something's broken and you got to get up and do it. But we're fortunate, like some of our apps, like literally, if it breaks, like we start hearing it at like 3 a.m. literally, right? And we typically then get it fixed by like 5 kind of thing. But yeah, I think if for traditional research only model, it is a challenge because it does cost money and effort, and research typically doesn't have this notion of how you sustain it. I think the most important thing is during the research project, get it to the point of having sufficient value that people will be incented to spend money to keep maintaining, because maintenance is going to be needed. And the main thing is is somebody willing to pay for it? So, but it is a challenge. And I think commercialization is something to consider. I've typically been an open source guy, but we're starting to think about some commercialization options simply because open source sounds great, but nobody wants to pay for open source because it's free. So, so I think it's something to consider.
Thank you, Dr. Kawamoto. It truly is a challenge, but with you three at the helm, I'm sure solutions will be thought of here shortly. Moving on to our next question. In the context of turning guidelines into action, how can your study's findings be used by guideline developers to improve their guidelines and/or related derivative outputs to assure implementation actions occur? We'll begin this time with Dr. Kawamoto.
Yeah, how to make sure things occur. I'm gonna have to think about it. Can I maybe pass it on to other folks and I'll come back to it?
Oh, you certainly can. Dr. Spiropoulos.
Yeah, I'll be happy to tackle that one. And again, keeping in mind that when the results of a clinical trial are published, by the time they get to the guidelines, there's always a time lag, usually many years. But be that as it may, I think what some of us on this panel are taking great efforts to do is actually to conduct actual pragmatic, or in my case, a clustered randomized trial to prove effectiveness of a CDS tool, you know. And I think guidelines start getting interested when they see, as part of a formalized impact analysis, an improvement in outcomes, patient outcomes using the tool. So it's not enough just to say that there's increased tool adoption, but what is the end result of that adoption, right? Is there a decrease in lung CA? In my field, is there a decrease in thrombotic events? And I think the importance of our trial, we powered it for clinical outcomes, which is why we needed nearly 11,000 patients. And as we saw, this is a positive trial. So for us, at least in the upcoming International Union of Angiology guidelines that will be published forthcoming in 2023, the use of CDS tool technology will be part of that guidelines because of these randomized trials that are being conducted. So I think that's the most important part, is conducting the RCT evidence in order to inform the guidelines.
Thank you, Dr. Spiropoulos. Dr. Dykes.
Yeah, so I think ours is a good example of trying to put guidelines into action. So for example, in our STRIDE study, we worked directly from the guidelines. So the British Geriatric Society, American Geriatric Society fall prevention guidelines. But you know, they were paper-based guidelines and they weren't very actionable. We ended up with algorithms that were difficult to implement in the primary care setting, and then not a lot of thinking around, you know, how would we, you know, integrate these into workflow. And so we were very deliberate with Aspire to start with looking at, you know, what are the 5 major risk factors? So we already had the algorithms on paper, but which ones are actually feasible for clinical decision support? And so it seems like there should be another step, right? You have these practice guidelines and the evidence is rated, but maybe we need to also rate the degree to which they're computable, right? And what we found is that, you know, the FRIDS, the osteoporosis, and activity and mobility to some extent were pretty actionable given the data that is commonly available in electronic health records. So, you know, today we don't have enough individualized clinical decision support, and we could start with, you know, the guidelines that are being used in practice and, you know, really finding which components are not only, you know, have good evidence behind their effectiveness if you do them, but can you actually implement them too, because you have the data you need in the electronic health record.
Thanks. That's a really great answer there. Dr. Kawamoto, can you close us out?
Yeah, thank you. I think it's actually quite relevant for lung cancer screening in that I feel that oftentimes guideline developers are forced to simplify their recommendations so that it can be implemented without too much tool support. In the lung cancer screening example, for example, there's, I think, active discussions to say, should we get rid of, say, you know, shared decision making as a requirement because people are finding it too hard, right? Rather than saying like, hey, should we actually start, you know, considering individualized risk for things like colorectal cancer and breast cancer screening. So I think it's important to reflect, to show that these kinds of approaches can be used to do more nuanced, risk-driven approaches to care, rather than saying we must, if we want people to adopt it, we need to make clinical practice guidelines and the recommendations something that without computer support, humans can reliably do. So I think that's an important part and really something that should be done. And it has a lot of policy implications because we hear all the time people saying, oh, you know, the complexity makes it so people can't do it. Let's make it simpler, even if, you know, a more complicated, nuanced approach might be actually better for population health if we can actually make that happen.
Thank you, Dr. Kawamoto. Terrific answers and terrific presentations by our panelists. Unfortunately, we've reached the end of our time for this webinar. Thank you for attending. For those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on this slide. You will select today's webinar, which will be indicated by date and title to claim your credits. You will have 14 days to claim your continuing education credits. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you will complete this survey to share with your feedback with us. Again, thank you again to all our wonderful panelists and our participants joining. Truly inspirational work, and we hope that we can continue the progress that you have started.
Everyone, bye.
Thank you. Have a good day.
Bye-bye.